Take my shirt off.
Do
Okay.
it. Do it.
We're live.
We're live now.
Yeah.
We're live.
You guys can stop talking about taking your shirt off. We're live. Don't do it.
Jeez.
So hello to everybody in Facebook land and anybody that might be listening in tonight. So we did a bunch of these back in the spring, and we figured it was a good idea to start trying to do some of these again. And so we've done some recruitment and brought some more people on. So we've done this with Eric and Jocelyn and TJ before, but we've got a new contributor, Stefania. Do you want to introduce yourself and talk a little bit about yourself?
Well, this is weird because I can only see your faces and you all know me. My name is Stefania. I'm an RMT practicing I'm in Vancouver. I'm currently not practicing. I'm full-time at one of the massage colleges. Mm-hmm. So that is my current role. I run the clinic there on a bit of leave at the moment, but back soon.
And hopefully they will still like you after this. But we'll
Hopefully I will still be smart enough for them after this. Oh, after this live thing. Oh gosh.
Yeah.
Can you imagine?
So I think another important thing to bring up before we go on is I put a message out and told everybody to bring their favorite beverage. So I'll just start with what I'm having. I've got a 12-year-old Delmore on the go. What are you guys having tonight? Not all at once.
I made an old-fashioned.
Nice.
Oh, nice.
Fat Tug IPA, Driftwood Brewery. If you're in Victoria or anywhere you can get this, it's probably the one of the best IPAs out there right now.
Maybe they can sponsor us.
That's what I was saying. We should do a road trip, and
I'm gonna reach out tomorrow.
Nice. So we've got the comments and everything turned on. So anybody that's listening in, feel free to throw in a comment if you've got a question or anything. But what we're going to look at tonight is clinical guidelines of low back pain. And we had a little bit of a snafu, which is probably more my fault than your guys's. And I read a different paper than you guys were reading. So we're actually going to chat about two different papers and how they kind of help each other, how they can help us as massage therapists when it comes to helping our patients with low back pain. So probably, I don't know where you guys want to start. Should we just talk about what a CPG is first?
Do it.
Yeah,
All
go
right.
for it. You need to find that.
Yeah.
Okay. So clinical practice guidelines, I love them. And a lot of the blog posts that I write, I use them because what they do is look at a whole bunch of the research papers that are out there, and they kind of compile them and look at what the best evidence is out of all of them and say, well, these are the guidelines we should go by. At least that's the best of my understanding about them, and that's the way I look at them. You guys can add whatever you want to alter or argue with me on that. But
No, I think that's a good summary, Jamie, because really the clinical practice guidelines are, if we look at the level of evidence pyramid, we got like way down here, we've got like blogs and opinion pieces. And then as we go up to the very top of the pyramid, we have the clinical practice guidelines, which are an amalgamation of all the best research below it. Usually it's an amalgamation of all the systematic reviews and meta-analyses, and they come up with, they analyze all the data and say, this is what is the least wrong information to apply to a specific condition or area of concern with the person. And you can look at them for anything, really. I mean, the stuff we're talking about tonight is low back pain, but I mean, you can find them for shoulders and arthritis and for neck and, name a body part, you can find a CPG for it.
yeah. And I think Stefania was making a great point before we started about massage and CPG. So do you want to comment on that now, Stefania?
You have to remind me what my great point was. Oh, that we don't have CPGs.
Well, there isn't any.
Right. A little foggy these days. Yeah, just that there aren't CPGs for massage. I know that's something that, a lot of us anyways have been talking about this for a long time, that we'd like to see that for the profession. And in the absence of that, I mean, there's nothing stopping these from applying. Like we've discussed already before this show, the top recommendations that they make, almost all of those are within our scope of practice. We can talk to the patient, we can de-escalate, we can reassure them, tell them that it's normal, that it'll go away. All of those things change their frame of mind about the problem. Yeah.
Great.
Do we want to just quickly, before we move on, do we want to just basically give a quick summary of what the clinical practice guidelines recommendations are, and then we can talk about them a bit more specifically about how those apply to what we do?
Sure.
Sounds good.
Okay.
Sure. So do we want to start with just simply starting out ruling out red flags? Or do you want to make a list of everything or just go point by
No,
point?
if we make a list of everything, it'll just be boring. It'll be like blah 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 lists of information. So let's simplify. That's what we want to do, right? We want to simplify things as much as possible so it makes sense. That's how I work anyway. That's how my brain works.
Simple.
That's what I like.
Yeah, great. So yeah, okay, I can go. Red flags. Rule out red flags. What are red flags for low back pain? Let's talk about that.
Tumor, infection, fracture, systemic disease, quadia equina, radiculopathy, kind of, sort of, but not really. It's more like a
Not really.
less than red, but it's still a big indicator. You got to catch it.
What was the second thing you said there, TJ?
Tumor, infection, fracture.
Oh, infection. That's not what I heard. Okay. Yeah, that makes more sense.
What did you hear, Eric?
So I think
it was blurry.
yeah.
Sure, it was.
So it's probably important to expand on that a little bit. So let's just take cancer, for instance. That's, typically when they're talking about a red flag, they're talking about a history of cancer. So it's really important for us to take into account that a history of cancer doesn't mean that they had cancer 40 years ago and now they're having low back pain. It's if they had a recent diagnosis that's a history of cancer, that should be a concern for us.
Yeah. I'd also take it as a screening for things like unwarranted fatigue, and this is in addition, right? It all kind of builds up, like stuff like unwarranted fatigue, pain that is completely unrelenting, doesn't respond to treatment, is worse at night, unexplained weight loss, that kind of stuff. Those are all flagged for cancer.
And I think too, just adding on to TJ's point, cancers that tend to metastasize in the spine, like prostate cancer.
There's some that are very specific that do that, and others that
aren't. So that the history is important for that too.
Okay, so if we move on now and we look at infection, we're looking at things like, I'll just throw one out: fever,
Fever,
swelling, redness in the area. What's some other ones?
Sure, swelling and redness without an explanation.
Yeah. This is getting boring really fast.
Yeah.
So let's wrap it up a little bit more. So when we start to look at fracture, it's not simply just going, oh, do you have a fracture? But we have to look at the mechanism of injury. So that's where the first aid geek in me gets really excited when I'm talking to a patient. Were they hit by a car? Did something major happen? But there's a whole host of other things that have to be present in order for us to rule out a fracture. For instance, like pain over the spinous process, the history, mechanism of injury. What's some of the other stuff that goes with that?
Suspected osteoporosis. There was something in the article, my brain's escaping me, but yeah, if you suspect, a continued corticosteroid use as well, which suggests like bone fragility, right?
Yeah. History of osteoporosis, maybe.
Yeah.
Right.
Traumatic injury.
Yeah. Yeah. So we look at the mechanism, right? Okay. So what are some of the quadia equina? What's some of the big things we look for? Our pelvic lady, Jocelyn. What are we looking
away, Jocelyn.
Erectile dysfunction. Acute loss of very quiet. It did, it got quiet in the crowd there. Acute loss of bladder or bowel control is a big one.
Yeah.
Yeah.
Maybe numbness and like that
saddle.
Yeah.
Saddle, is it analgesia? Did I get that right?
Analgesia. Yeah.
Yeah.
Paresthesia.
Yeah, thank you.
Analgesia would be like pain relief.
It's not right. Sorry, that was my fault. I did that. I put that out there.
So saddle paresthesia. Okay.
Yeah.
I think that's the majority when it comes to red flags. Am I missing any?
I think those are the majority. I think the thing to know with these though too is that like 99% of the time somebody comes into the clinic with low back pain, it is not any of those things.
Yeah.
Right.
Yeah.
So,
and I know like I believe I've looked over the paper that you guys looked at, but even in the one that I looked over, it shows that like 1% of the people are actually dealing with that. Like 1% of the people, that's actually an issue when they come in. And one of the things that I noticed in a couple of the papers that I've read on clinical practice guidelines of low back pain is that it sort of takes a whole bunch of these things together in order for it to be an actual red flag. So it was continually promoted that it really comes down to the clinician's what's the word I'm looking for? Their ability to recognize that something's going on. So it comes out to their expertise. It comes down to the clinician being able to make that decision and go, something doesn't seem right, so I'm going to refer you to a doctor to have that looked at.
Right.
Which I think is a good point to make, Jamie, because I think that really fits with when we're talking about evidence-based practice, where you're looking at research evidence, your clinical expertise, and then the patient's, the patient-centered care, is that you look at, here's the research evidence, which suggests all these things we've talked about, but then below that, you have your clinical expertise, and that's where you need to use your expertise to make sense of what you know from the evidence and from what you've seen historically as well. So I think it's important that's a good point you made that. I think it's great.
They're just going to take a little bit of experience, right? Which is the thing that you can't really teach, and which is why we depend on our schools to give people a robust education and experience so that they can see some of this stuff. So hopefully it's not the first time that you have a complicated case walk through your door on like your first year out, because it's tough.
Yeah. Well, I think there's something interesting there too. Like I remember in school learning about, saddle paresthesia or like these red flags. And the answer was, if someone has a red flag, you send them to the doctor. And I remember being in my first year of practice where people came in with the red flags and I go, oh my God, I need to send you to the doctor. You're like, yeah, I've been to the doctor and I'm waiting for surgery. And now what? And I was frozen. I didn't know how to treat this person because we never talked about, but what if they're just waiting to get treated, right? Because those people are on a wait list for surgery usually.
Which actually brings up a really cool thing that was highlighted in the paper that I read, because when it talks about looking at the clinical guidelines for low back pain and how we manage it, is that it says, despite increased spending on health services, patient outcomes have not improved. And one of the big reasons that it points here is that like 25% of patients who experienced pain for 12 weeks were referred for surgery. And when we look at the long-term and diagnostic effects and all those things like that, that's not a quality thing to do, and that's why they're having the poorer outcomes, is because they're being referred for surgery so often.
Yeah. Surgery is still being recommended despite the guidelines, suggesting against it for all kinds of things: shoulder, knee, back.
Yeah.
Well, there is a bunch of papers which I know we're not using for this discussion, but there's a bunch of papers out there which I think we're probably all aware of, where they look at, if you like, the sooner you get surgery for a back, shoulder, neck, hip, knee problem, the worse your outcomes tend to be.
Mm-hmm.
Right? Even though, so none of the guidelines recommend them, but that's still common practice, which is unfortunate because people are getting care that is actually against the evidence, and their outcomes and people are suffering as a result of it.
And the outcomes are terrible. So now that we've kind of ruled out red flags, why don't we look at the next thing, and which I was sad that in the paper that I read, there was no mention of this, but looking at the yellow flags, and we really push for the biopsychosocial aspect of pain, and that's where those yellow flags come in. So I'll let you guys discuss it since it wasn't in my paper. I know what they are, but you guys go ahead and chat about what the yellow flags were that were pointed out in the paper you read.
So the beliefs about pain and activity being that activity is going to hurt or it's going to cause more pain. Treatment preferences that don't fit within best practice, and social support. I think another, outside of this paper too, something that we discuss in our low back, pelvis, and hip course is an overprotective partner. Is that what that is, Eric?
Overprotective partner,
yeah, or over-involved partner.
Yeah, spouse, friend, loved one, overprotective. Yep.
That's a good one. I've never heard that one before. I like it.
Yeah. And I think it's important, like when Josh, you were just talking about the expectations of treatment. I know one of the main ones is that people just expect passive treatment, not active treatment. And part of that is, that they're coming in, they just want to lay on the table and be treated. They don't want to do any exercise. They don't want to do any movement. They don't want to be necessarily actively involved in the actual treatment that's going on. So that's one of the things
I'm going to challenge that a little bit, because I wouldn't say it's always that they don't necessarily want to. It's just that they think that there's something wrong with them and they have to go to someone to get it fixed.
Well, expectation.
Yeah, there's an expectation there. So sometimes, again, like if we want to promote, resilience and self-efficacy in people, and if we can show them that they can manage their own pain by activities and movement and graded exposure, and that movement is not harm, that I feel like that's going to go a long way in terms of giving people or empowering them to help themselves.
I think it really can. And, just because I like challenging my own biases here, right? Like low back pain patients follow a similar trajectory of improvement regardless of the intervention. So let's not get too carried away with thinking that we can do the right thing for the person at the right time. Although I 100% am on board with, making sure that they feel good about doing the activities that they want to do, especially if there's no good reason why they shouldn't be doing them. And we help them to not avoid exercise and feel confident and all those things. All amazing. But I think that maybe it takes a certain kind of patient. I'm speculating here. Maybe it takes a certain kind of patient who's ready for that to really jump on and go forward, because like I said, low back pain patients follow a similar trajectory of improvement regardless of intervention, active or passive.
Yeah. Well, most musculoskeletal injuries are the same. They follow a certain trajectory of how quickly they're going to improve. But interesting enough, like I look at you, Tej, and Joss and Stefania. I know that you do this too, because like Joss, when you teach, you talk a lot about communication, but Tej, you've got an assessment course. So if you have somebody that's coming in and the knowledge you have about these CPGs and you're going to assess the low back, what kind of things are you going to communicate to them as you're going through the assessment process with them?
Well, it depends on who they are. Right? First thing I try to do is obviously, maybe not, well, it's obviously to you guys, but not to everybody else. So I'm trying to bond with you as fast as possible. So I have a completely different approach. If one person comes in and they're saying, my SI joint's locked or it's out of place and I've got this thing in my back and it's twisted, or it's, they come in with these using hyperbolic language that is, focused specifically on some kind of pathoanatomical specific tissue-based narrative, then I'm not going to try and play that down right away, at least. I'm just going to listen a lot and validate them and reassure them if I can, if it's welcome, because sometimes reassurance isn't cool either, right? People come in and they're up here with their fear, and we can't just meet them with that same amount of reassurance. We got to give them a safe place to vent and calm down a bit and just basically say, I hear you. Wow, that's a lot. Give them space to do that. So, I handle one patient like this and then another patient completely different. On the other end of the spectrum, we got these people that are, information junkies and they want to hear everything. So one of the things that I do to try and assess that out is I'll ask people right away on the first assessment I see them is I'm going to give you 3 statements, and then this will help me understand what kind of RMT relationship you'd prefer to have. So, attitude number 1 would be something like, I just want to get out of here. This is an inconvenience. I just want to get back to the things I want to be doing. Do whatever you have to do. I'll do whatever I have to do. Just tell me what to do. This is personality type number 1. Number 2 would be something like, I have some ongoing things that are, they don't really get in the way of my life too much, but it kind of hurts a little bit. And massage therapy is one of my favorite ways to deal with it. And then number 3 would be something like, relaxation is 100% the most important thing that I get out of the treatment. And regardless of where I hurt, a good relaxing massage, takes me down all the way. So I kind of let them decide right away what kind of relationship they want with me, so that I can put on the right hat to fit them. It's the best we can do. Nice.
Joss and Stefania, with your communication stuff, what do you like to do?
Well, I actually have a question for TJ with that being said.
Great, yeah.
So if someone comes in and they hold a belief that, my SI joint is out, or this pathoanatomical belief, or and they're an information junkie, they want to know every possible thing that's wrong with them. Mm-hmm. Do you ask them, what are things you've heard? What do you want to hear? what do you think it is? And then does that, in terms of the relationship that you're trying to build with that person, does that influence how you communicate with them?
Absolutely. That's, thanks for putting me on the spot, because it's good to think about this stuff. Often I do things like automatically in the moment. It's a bit like improv, right? You just want to listen to them and you want to work with them. But I don't often think about why I make those decisions at the time, which is part of teaching, right? So you want to be able to help them understand why you make these decisions. So if I'm hearing your question right, I think I might have gathered enough information by that point to get an idea of what they think is going on. So I never ask people what's going on necessarily. I might ask them, what's your understanding of what's happening here? What do you know about this? Because that's more important for shaping how it is that I speak to them. So like I said, if they say, oh, my sacrum's locked up or something like that, then I might even say to them before I start the treatment, well, I'll do my very best to loosen it up. So it's kind of like the opposite. So they can expect that that's what I'm trying to do. I'm not going to say that I'm going to unlock it necessarily. Yeah, exactly. But I think during the treatment, with a little bit of conversation, hopefully I can assess whether or not they'd be willing to hear something like me say, would you be surprised to know that, if you put 12 osteopaths in the same room, they can't even find the same thing on the same person 2 times in a row with some of these SI tests. So,
that sounds like the beginning of a joke.
What does it mean?
Yeah, it does.
How many osteopaths does it take to, I don't know.
To unlock an SI joint.
Yeah.
Love it.
Yeah.
Awesome.
Well,
Sorry, I didn't mean to interrupt, TJ. Sorry.
I think Teach really hit a good point there, that it's a lot of improv. There's no one way to do it. You have to customize to the person who's in front of you.
Totally.
And I think that's a really important thing too, because I know from years of teaching that people want to be told what to do. They want to follow this very specific clinical reasoning pathway. And when you're treating people and you're in like this biopsychosocial way, there is no linear pathway, and it's always a challenge to get people to, like other therapists, to buy into that. And us 5 have talked about this before about, being comfortable and being uncertain, because there is no linear, there's no analytical way you can just be like, this is what you do when you see this. Yeah. When you see somebody's got SI pain, you follow these steps and this is what you're going to find. It doesn't work that way. And I think it's important. And I think TJ did a great job there of saying that we have to kind of meet people where they're at, and we kind of have to see what their beliefs and their expectations are. And then we have to kind of meet them like in a way that doesn't push them away, but brings them in. And I think a big thing, and we all know this, is that one of the biggest predictors of people not getting better is if they hold these very pathoanatomical beliefs. Mm-hmm. So if someone comes in and they say, my SI joint is stuck and I need you to release it. And you're like, I'm going to release your SI joint. Then every time they feel something in that area, they're going to come to see you because they're going to feel that their SI joint is screwed, and then they need you to fix it. And I think it's important to have that conversation with them and say, okay, like what you said, TJ, like, would you want more information about this? Or would you like to know more about this? And that way you can then kind of challenge your belief without spewing that information at them. You're asking them for permission to change their story. And I think that's really, really important.
Tying that into the CPG article that we were reading, one of the things they really recommend that is like one of the clinical practice guidelines is reassuring patients with acute low back pain of a favorable prognosis. Yeah. So regardless of what they think is happening, you need to tell them that they're going to be okay.
Yeah.
Yeah. And I think what both of you were saying goes to that as well.
Yeah. And that's the thing that's with in every single CPG for any musculoskeletal complaint at all, reassurance is always is almost always there, right? And you reassure by educating people about what's actually going on in their body. And when we can,
that's true.
Yeah.
You sorry, say that?
I don't know that that's true. Sorry, I interrupted you, Eric.
No, that's okay.
Say, you reassure people by educating them on what's happening in their body, but I would argue that if you're educating them incorrectly, if the narrative that you feed them or that you give them, that you offer them is like really pathoanatomical, that's not actually reassuring. That's dependency building. They now think that they have to come back so that you can unrotate their pelvis every week.
Right. Yeah, that's a good point. No, thanks for saying that. you're educating them based on on evidence, on based on what we know.
Yeah.
To reassure them, right? You're not educating them based on like, oh, I found these subluxations and they need to be fixed. They need to come see me 3 times a week for the next 4 months. That's not good education, but evidence-informed education is I guess is the key there to reassure them.
Can I make a suggestion here? So since we're talking about all this, does anybody have a story that they're willing to share about having that kind of an encounter with a patient where they had their understanding was here and you wanted to get them here and you're wondering how you're going to navigate
that? I think I probably have several of them, but they're just little things. And we talk about this when we teach, where it's not necessarily that you vomit pain science education on them. You just plant little seeds. And I've vomited on plenty of people. But it's way more effective to just plant those little seeds. So I haven't literally puked on anybody in the clinic, but it's planting those little seeds. And I just did this last week with a nurse practitioner that was talking about her SI was locked up, and I said, well, read this article that I wrote, and they said, well, I totally agree with everything you said in there, so why does mine bug me? And I'm like, well, that may be something you have to talk to a counselor about, because I don't know if I can dig that deep to get into that. But you plant those little seeds and you work along as you go. I don't know if you guys want to add more to that, but that's what I found anyways.
I have a story actually, because I had an email from a patient I saw a couple months ago or a couple weeks ago today, just because I'm no longer at the clinic that I was working at. But I don't know if those of you who are familiar with my videos that I post on Facebook, but I made one about a patient that I saw who was vacuuming and strained their back, and they went to physio. They had something like 40 sessions of physio, and the physio didn't believe them and said that they weren't doing their exercises. And then they went to chiro and they wanted to have a kid, and the chiro said that their pelvic patterning was atrocious, and if they thought their pain was bad now, just wait until they have a kid and it's going to be worse. Yeah, it was like, she sat in my chair and she was she cried when she told her story. And she held so many unhelpful, like, pathoanatomical beliefs about her SI joint, her L5-S1 segment, her pelvic floor, her pubic symphysis, like all those areas. And I just, when she finished, I said, what do you want to hear? And what would make, because I just wanted to be like, look, this is all not helpful. And I want to say things that is going to help you feel better about what is going on with your pain and what is going on with your body, and help rebuild that relationship between you and your body, because it sounds like there's a bit of a distance there and there's some frustration. And so anyway, we talked for 40 minutes of that hour-long appointment. And
just get her on the table.
Yeah, I know, right? And so we talked for 40 minutes, and she left, and I wasn't really sure, because we debunked a lot of myths about what was going on with her pain experience. And I thought that, oh my goodness, I just vomited all over this person. But I also felt too, if we go back to that improv, this person was someone who was at the edge, and they needed to hear something that was reassuring about their body. And I never saw this person again. And then she emailed me today, actually, and she said, I haven't experienced any pain since I saw you in practice, which made me cry. But yeah, it's making those calls, and it's, what can I say to you that is going to make you feel better about your body and what's going on?
That's amazing. I love that story. Something I think that is really difficult to get across to, because we're all in the continuing ed world now, but if you haven't had that experience of somebody who is on the edge, and from what you said, it wasn't just the threat to her body and that her pelvis was misaligned and all these kinds of things, which can be harmful enough and help people avoid the things they want to do, not feel robust and capable, and therefore then also get a whole bunch of not only psychosocial but actual biological deleterious effects, right? Because they're not loading their body.
Yeah.
But this professional, this healthcare professional, told her that she couldn't have a child, or put up this threat to her motherhood, or how her body's going to be. I mean, putting those two things together, just fucking heartbreak. Can I say fuck on Facebook Live? I don't know.
Yeah, you should.
We'll find out if Facebook removes it or not.
It breaks my heart.
Yeah, and and there was another. Her husband divorced her because she couldn't have kids, and she didn't want to because she was scared she was going to be in more pain.
Wow.
And then there was an opiate addiction in that too. So this is, yeah.
So I would also speculate that if you were a practitioner who, another practitioner in the line of practitioners that she's seen that just reduced her pain to a leg length discrepancy and a crooked sacrum, again, nothing.
Yeah.
It would just be another failed treatment. And I've worked with these people. Another failed treatment. It's more just more failure. And if these professionals who are holding on to these narratives, these old pathoanatomical tissue-based narratives, or strictly tissue-based narratives, because I can't just throw that entirely out, but if they're holding on to that and putting that onto people, then what I think they experience in the room is, this is another practitioner who's a specialist and sounds pretty smart and knows what they're doing. If they can't figure out what's going on with my back, then either all my practitioners are idiots or I'm more screwed up than I thought I was. Those are the only two logical conclusions I can think of, and neither of them is okay.
No.
Yeah, those are both really damaging.
Yeah.
This is really interesting because when I look at the paper that I read, there's a section in it that says, is it always necessary to determine a cause? And it makes 2 points of why it's not. So it says, first, the tests used to identify anatomic sources of non-specific low back pain have unacceptably low validity, so the diagnoses are nominal. For example, the clinical utility of describing patients as having neuropathic back pain has not been established. Screening questionnaires to use to detect this condition have unclear evidence for validity, and there's evidence that drugs for neuropathic pain lack clinical effectiveness. And second, structural diagnoses encourage the use of structure-based treatments that have been shown to be ineffective. So everything we were just talking about, right there.
So you're saying you read a better paper?
Uh-oh.
You read a different paper.
But I think these are all important things to know, though, because we know, like, what all these papers suggest is that we know that the pathoanatomical model is very poor for people with pain. Right. Once you rule out the bad stuff, the scary stuff, we know that those anatomical approaches, those structural approaches, just do not work very well. And we know that those approaches actually help put people in pain. And when we're looking at yellow flags, which I think that's where this conversation started.
Yeah,
way back when we started talking about yellow flags, is that we know that I'm sorry, I don't have the reference available on me, but I do. It's back here somewhere, like where all the papers I've read are. Is that we know that one of the yellow flags is past people you've seen. The number of practitioners you've seen is a yellow flag. Yeah. So that's a really important thing to incorporate as well. So when they talk about yellow flags, we have to be aware of, like, what story has been perpetuated again and again and again with this person in front of us, because that can sometimes be a lot of crap to wade through. What have they been told is wrong with them?
Yeah, we don't see their backpack. When they come into our room, we meet them, and we don't know what's in their backpack.
Yeah, but that could be heavy.
Sometimes it really, really is.
Yeah, but we also should say that heavy backpacks have no association with
back pain.
With back pain. So
the literal kind.
Yeah,
so don't worry about
I think we just lost somebody.
I think we just lost Jocelyn. I'm sure she'll find her way back.
Uh-oh.
Oh yeah.
Jamie, it looks like you shared the first one. You're sharing the other one as well?
I'm getting the other one right now.
Okay, yeah.
Wow. Okay. Good
So
stuff.
I just posted the one that you guys looked at, and the first one that I posted was the one that I've got.
Got it.
For anybody who's watching.
I think it's important too that I think it's good that, I mean, I don't know how many people are watching right now, but hopefully people will read these papers because I think it's actually empowering for us as massage therapists. I know we don't have our own clinical practice guidelines. I know we don't have our a lot of the guidelines don't include massage or manual therapy, but I think it's really important for us to understand that the things that are listed in these guidelines are actually within our scope of practice.
Yeah.
A lot of it, right?
A
So
lot
I
of
think,
them, yeah.
yeah, I think it's important to know that and to be aware of that, is that even though it doesn't say do massage therapy, it doesn't mean we can't touch people nicely. It doesn't mean we can't reassure them. It doesn't mean we can't get them moving and exercising. I think that's really important to emphasize.
It also means that we can
Jamie.
still recognize the psychosocial factors. Like that's well within our scope. And granted, we can't counsel people, but we can recognize that those things are contributing factors to a person's pain experience.
Yeah.
That's a good point too, because I think what happens oftentimes, and I mean, we've probably all seen this on social media before, and we've probably received personal messages and people asking questions in courses, is that they think that psychosocial means that we're counseling people or we're just talking people out of their pain.
Mm-hmm. Mm-hmm.
Right. And so I think it's important to know is that that's not what we're saying. That's not what's happening.
No.
Right. Just recognizing those things. You're just recognizing to contributors to their overall kind of systemic pain sensitivity.
Yeah.
And you are, if it's within your scope, if it's things like unhelpful pain beliefs, if it's, movement is going to cause more pain, if it's things like, I need to be fixed, I need to get my rib put back into place or whatever. If these unhelpful beliefs, if there's these fears, these anxieties, well, those are psychosocial drivers, and we can address those with just education and reassurance. It doesn't mean we're counseling. I think that's the thing that's I often encounter lots as people were like, whoa, you pain science guys are just talking to people about pain and then they're getting better. Like, that's not what we're saying at all. Listen to the words that are coming out of our mouth. This is not what we're saying. But they're things to be aware of.
Well, and what you said,
do a lot of what we do, but we can use our education and with our hands, with our touch to infer strength and infer resiliency, to infer that they're okay. It doesn't mean talking to people about pain and then they're getting better. Like, that's not what
I don't know what's going on there. You guys having issues too?
that was a weird thing.
Kind of glitch there, I think.
Yeah. I think we've lost Jocelyn.
There's lots that we can do, right, with even the assessments that we do, or resistant range of motion or what have you, as ways of decatastrophizing, as ways of saying, hey, look, isn't that fantastic that you have this? Isn't it fantastic that we've ruled this thing out? Those can be really reassuring as well.
I love that you just went there, because my paper talks a lot about cognitive behavioral therapy as one of the things that we can use. And as we know, graded exposure stems from cognitive behavioral therapy. So during that assessment, if we can do some graded exposure, some adaptive movements, some different things with them to build that resilience in them, and we've got Jocelyn back. If we can do some of those things in order to build that resilience and show them that they're not completely broken and that we can start building them up from there, then that's
And I think it's important to touch on the fact that even though you just said the paper mentioned CBT and that graded exposure is basically CBT, we are not doing CBT because that is outside of our scope of practice. We're doing graded exposure. So, it's difficult for you to put weight on your foot. Can you put weight just on the heel or just on the outside edge or just on the toes? How does that feel? That's modifying an ADL. That's ADL modifications, which is absolutely in our scope of practice. Not CBT.
As is graded exposure. It's just a form of CBT.
Yeah.
We're not counseling them with CBT. We're moving them. Yeah.
No, we just kind of let that take care of itself, right? I mean, showing people how to do something that they can't otherwise do successfully or have been having a hard time doing successfully. And then you get them, hey, I'm having trouble getting in and out of bed without throwing at your back. That happens a lot.
Yeah.
Or getting out of a chair or putting your pants on or whatever. It's like, that's the first order of business, my friend. So then we get them to do that, and they can do it repeatedly. And hey, I'm not doing, psychological intervention, although it's happening. Like, can't bend forward. Guess what? I can just show you how to do a pain-free deadlift. Oh, what? I must not be as broken as I thought I was. So
great.
take care of itself.
I feel like a lot of this stuff is kind of like, unless you're saying, because there's titles to it, but a lot of these processes, whether it's graded exposure or if you're utilizing active and reflective listening during an interview, these are all passive processes that are totally within scope for us to do. So it's just being mindful and paying attention and then making modifications.
So now that we've beat red flags and yellow flags to death, we're getting more into the treatment end of things now. So talking about a little bit of graded exposure, exercise, what's some of the other stuff in your guys' paper? Because it's a funny thing between the two papers that we can get into that's different, but what's some of the recommendations in the paper that you're on that we can use with people?
I'm just getting to the right page. Someone else have it handy?
There's a lot of things that say what not to do. And that's what you get with a lot of these research. It's like, don't do this, don't do that, right? So it says, don't do bed rest. Don't have routine medical imaging.
I think that's a good thing. Don't skip over that, but don't do bed rest.
Yeah.
That was the big recommendation 20 years ago.
Yeah.
It was, but the
Right.
Cochrane review is like, it said that on bed rest was saying that it's like 2 days is as good as 2 weeks, except it doesn't have the deleterious effects.
Yeah. It says don't use drugs.
Yeah.
Yes.
Drugs don't really help. What else do we have here?
Steroids.
No routine imaging.
No routine imaging. We said that. Yeah. And it says, avoid invasive treatments.
Yeah, I was just going to say injections.
So no spinal injections, no surgeries, obviously. These things are all like, I mean, you would be doing those things if there were red flags or if there was radiculopathies, kind of things that weren't resolving. Yeah, and I think they all involve education. So telling people and reassuring them that this will follow a relatively predictable timeline if it's acute, right? Reassuring them that they're not broken. And then it's encouraging meaningful daily activities is the other one, really. I mean,
So basically, don't take time off work if you don't have to.
yeah.
Yeah.
Right. Yeah, I think that's a big deal.
That goes back to one of those psychosocial things is, talking to the patient and encouraging that if they don't have to take time off work, don't. But then also discussing, does your work have a graduated return to work program? Can you go back and do a few hours a day and gradually graded exposure yourself to work? Are those things available? So that's some of those psychosocial things that we can take into account where we're not counseling them, but we're like, hey, if that's available, that's a good thing to use. And that's well within our scope to be able to talk to them about.
I was thinking, like, you made me think of two things there, Jamie. Like, first thing is that I think that a lot of people get put on light duty, and then they end up sitting on their backside all day, which for some people ends up making them a lot worse. So, that graduated, return to work, it needs professional oversight. You can't just have somebody just do it. Maybe we need OTs to participate, or somebody has to be the quarterback there because people get left behind. And the other thing that I'm thinking of is that, getting people back to work isn't always as easy if, as it sounds, even if they're being encouraged to by healthcare professionals, because their adjuster for ICBC or their lawyer might be saying, hey, I know, Frank, that you want to work, but if you go to work, and keep in mind, he feels well enough to work, which is a good thing. But they're saying, don't go back to work because it looks bad for your claim. And if it looks bad for your claim, then we can't get as much money. We can't get your truck fixed. And then you can't carry on with your agriculture business or whatever, Yeah. So there's a lot of layers to it.
I've heard that too from patients.
Me too. Yep.
Work low back pain, that for their company, it looks better if they take a big chunk of time off rather than small increments. It's better for the company if you take off 3 months than if you take off 3 days, go back, decide you can't do it, take off 2 days again, right?
Yeah.
It's challenging.
I don't know if you've ever seen the charts on what it looks like when people with low back pain go off work, but sometime around the 3 month mark, it's like a coin flip of whether they go back at all.
Mm.
Well, I think I've talked about this before when we've done these, but before I was an RMT, I was an industrial first aid attendant. And I remember having a discussion with the WCB rep that would come into the sawmill that I worked at. And he told me that their studies have shown that if somebody's off work for 18 months injured, chances are they're never going back to that job.
Yeah, I bet.
So that's huge.
Well, I think too, like if we're looking at psychosocial, just adding to the layer as well, is how much work stress is in this person's life, and then how much it's absent with them not being at work. And I think that might be another, this is what comes up for me anyway, is that I see people who are in a motor vehicle accident. For those who are not familiar or not in BC and don't know what ICBC is, it's our motor vehicle accident insurer. And they are off work for a chunk of time, and then they attempt to go back and their pain gets worse. Their lower back pain gets worse because they didn't realize, or perhaps it's something that gets mentioned to me during treatment, how much of a stressor that their work is and how much that is now playing into their pain experience.
Yeah.
Okay.
You know what I think? Sorry, go ahead, Jamie.
No, go ahead, man.
I was just going to say that we spend like the majority of the time here talking about yellow flags and soft skill application.
Yeah.
And I think that is super awesome because I don't think that there's another healthcare profession out there providing musculoskeletal therapy that spends as much time with people as we do. So we get time to hear their whole story, pick out little pieces, and we don't need to jump on it right away because it is annoying. I don't know if you guys like feel this sometimes, but like you ever talk to somebody and like you can see behind their eyes they're just thinking and they're just waiting for their turn to speak, and that kind of puts you off, right? It might hurt the relationship. But for us, we get to sit back, take a chill stance, and have the time to listen to our whole story, pick out the things, put them in our back pocket for later. We address them later, and we have all that time to slowly unpack and slowly leave that trail of breadcrumbs. If we feel like there's some unhelpful thoughts, or behaviors, or ideas that are lurking around in there, and they can get there by themselves. It's pretty awesome. We have the best setting, I think, for implementing all of these soft skills in the context of the BPS.
You got Keith agreeing with you. That's high praise right there.
Yeah, we got a great comment from our buddy Keith Meldrum, who fully agrees. We had Keith with us earlier in the year.
We love you.
For those of you that don't know Keith, he is an advocate for the patient experience when it comes to pain, and he raves about his massage therapist and about the fact that we get to spend more time with our patients than anybody else. So love the comment, Keith. Thanks so much for listening in tonight.
Yeah, and the interview doesn't just stop after the sit down. It continues while that person's on the table as well. So I think that's also kind of another powerful thing we have as massage therapists is that, the chit chat doesn't always stop right when the person gets on the table. Yeah. It happens while they're on it as well.
Yeah, I don't think there's not a healthcare profession out there better suited for treating in a biopsychosocial way than we are. And I'll stand behind that 100%. I think what's that?
And Ken Leong agrees too. I quoted him in my blog post.
Yeah, that's right. Yeah, Ken said that recently too. Yeah, I think it's true because I think it's just a matter of us accepting that and realizing that, and if we can accept the biomedical stuff that we've been taught, and that's important. But if we can realize that in persistent cases where people have been hurting for a long period of time, the biomedical stuff doesn't matter as much as the psychosocial stuff. So how can we support people while they're still hurting, and how can we help them on their journey of recovery or journey of just learning to live well with pain? And I know from people like Keith and other advocates for the patient experience I've talked to, that is like the most important thing. And in my own clinical experience, that's the most important thing is people, if you can support them on their journey and you can just be there for them. I mean, that is more powerful than any magic technique that we use. And I think as a profession, we need to embrace that. And that goes with what you posted the other day, Jamie, about going big.
Yeah.
For us is like, we need to go big, and we just need to accept that we have this very powerful, very important way of interacting with people and supporting our patients. And I think we need to embrace that, and because if neglecting, I think it's neglectful to ignore it. And then I'll stand behind that 100%.
Yeah. Well, I've already said my piece on it, so I agree.
Yeah. So here's and this might be an entirely different stream night with our topic of yellow flags, but all of us instruct. So what do you think some guidelines should be for psychosocial guidelines for pain or lower back pain for this example?
I'll let you guys comment.
Well, what do you mean guidelines? Like guidelines for treatment?
Or for
Sure.
communication?
Yeah. Communication.
First thing I can think of is that when you're dealing with a chronic pain patient, I'll just say the one thing is this, like, in your interview, you ask a question and then you shut up and you let them talk.
Let them talk. 100%.
Just the biggest thing in the room is their pain.
Shut up and listen.
Yeah.
Yeah.
And don't repeat back to them what they said with different words.
And
Right?
you can repeat back if I'm hearing you right, this is what I'm hearing.
Yeah.
Sure. Yeah.
But I think one of the big things is it goes back to that letting them talk, but understanding that when we're letting them talk, that doesn't mean we're counseling them. That's just, and maybe they just need to vent about whatever their thing is. Like I know there's an older gentleman that I used to see who had PTSD, and this guy was in his 80s. He was a beauty. He came in to see me 6 or 7 years ago. Was like, okay, he had some low back pain, treated him, he went home. 2 weeks later, he came back in, and as he was walking out, his wife turned around and said, "You're booking in once every 2 weeks from now on because you're a different person when you get home." And I honestly believe that part of the reason for that is because in his case, his PTSD was associated with a fire. He knew I was a firefighter. He could get on the table and he could swear, he could vent about whatever, and I didn't care. And he didn't have to hold back. He could say whatever he wanted for that 45 minutes. He had a window to say whatever the hell he wanted and vent about whatever he wanted, and went home in a better mood. I don't think what I did with my hands actually made a lick of difference. Because the fact that this guy could just, for 45 minutes, could say whatever the hell he wanted, and nobody cared. There was no judgment about it.
Yeah.
I'm not counseling him. I'm just letting him talk.
And I think with that being said, I think it was Eric actually that said something in a course the three of us taught, was that you're just holding space for someone. And that really like resonated within me, because I'm like, it's not counseling. I'm letting someone vent or tell me their story or just be heard. And that's the most important thing, and validated as well for what's going on within them.
It's something that I've as we've experienced, because we actually end up putting on our real good listening ears and practice the soft skills, and it takes a lot of practice, but it's something that I've been thinking about how is the best way to translate this into education for people who aren't quite there yet, or want to start having those kinds of experiences that we're talking about. And so what I started doing in my courses is that, like, I have a lot of good stories because I worked in some clinics where I worked with a lot of really complicated cases. And so I know what it's like to have somebody come in, and when they start venting, it's really difficult sometimes to remember that it's not about you, and that they, like, their energy, you end up taking it on a little bit. So I know what that experience is like, and how rewarding it is when you know it's not about you, and you let them vent and you validate them and you reassure them, but not too much. Don't talk too much because it's their turn and all that kind of stuff. But I started doing it in my courses to try and have people have a little bit of that experience. So I'll put on my improv hat. I'll like put on a hat, get into character, and I'll have them conduct an interview, and I'll just berate people, because I can think of a guy that I had just a couple weeks ago where I asked him one question, and no shit, he talked for 12 minutes. Venting for 12 minutes. I don't know if you can imagine what that's like, but I want other people who haven't had that experience to know what it's like and to feel more prepared when they're in that space. How can they be there for that person?
I think that's really unusual too, speaking for 12 minutes. Remember at one of the San Diego summits, I don't remember who the speaker was. Maybe it was, Sharna Prasad.
Oh, Sharna, yeah.
Yeah, wasn't she the one who was speaking about how long they actually speak for? If you let your patient speak uninterrupted, it's actually much shorter than you expect. It's like 2 or 3 minutes, even though it feels like, so 12 is well done, you.
And I think it's common too that I think the average healthcare provider interrupts after, was it 8 seconds or something?
Actually, I think what Richard posted on Instagram today was 18 to 23 seconds now.
Oh, is that okay? Yeah, there's an 8 number. Yeah, still way too short.
And I think that the 8 seconds comes in after the person stops talking. You wait 8 seconds before you respond. Yeah.
Okay, good. Yeah.
It's amazing that we've spent this much time talking about soft skills that aren't so soft. They're pretty hard sometimes.
Well, or essential.
Yeah.
I think these skills are way more complicated than learning how to like touch people.
Yeah. Absolutely.
As far as touching people, I learned everything I need to know in like term 1 and 2 of massage college.
And that's a hard thing, I think, for people in our profession to accept, is that, when you hear this stuff, it sounds like you're saying your touch is useless. You don't need skills, but no, you need skills, but your skills lie more in your ability to connect with people more so than with your hands. And your hands have to be good, obviously, but I mean, it doesn't take a magic training to have good hands. It just takes practice.
Yeah.
But I
Practicing people nicely.
Yeah. TPNing them.
These take more practice, Take practice, but these take more practice.
Yeah, for sure. They're all important skills.
I think too, like what we do. So if we're reassuring with our words and then we're reassuring with our hands, it's more solidifying to that person's experience.
Sure. And we can reassure with orthopedic assessment too.
Yeah.
I use my ortho assessment a lot of the time to show people what they don't have. You're like, well, good. That's good news. You don't have that.
Yeah.
Or what they're capable of doing that they maybe didn't think they could do.
Exactly.
Yeah.
Manual muscle testing.
Yeah.
If you had this thing wrong with you, we wouldn't be able to do this.
Yeah.
Right. So I think that's
like
great.
mentions manual muscle testing, and I don't even remember what the scale was in school, but I know it was 1 to 5. Whereas now I get people to do it, and I push on it. I'm like, oh, good, look how strong you are. You can resist that.
Yeah,
you're normal. That's great.
Yeah. Way to go.
You're not broken. Yeah.
And
I think that's an important thing to actually to mention too, because we have been talking about soft skills, but I think it is important to know that we're talking about that stuff, but we're not dismissing the palpation, the hands-on, the muscle testing, the assessment stuff. I mean, that stuff's important for what we just talked about the reassurance and education, right? Letting people know like they're okay, they're safe, they're strong, they're resilient. All those words we like to throw around and pretend we know what they mean really well, but you know what I mean? Like showing people that they're okay, right? So I think it is important. Yeah.
Or maybe sorry, Jamie, go ahead.
I was just going to say, it's interesting when we look at the clinical guidelines.
Yeah.
It talks very little about how to touch people. It talks about all the things a lot more. So when we look at it, what has the bigger influence? The soft skills or the hands-on skill? All the clinical guidelines talk about the soft skills.
Yeah.
Well, these also aren't geared towards massage therapy or even physiokinese. Like this is, in the medical system and primary care providers. So they're talking mostly about what GPs,
Doctors,
right? Some of the reference documents, I know a couple of us, we were talking about it before, Jocelyn, TJ, you both read reference documents as well. Some of those reference massage, and they're actually pretty dismissive of it. But I think that's because they're looking at massage in the way that it's typically understood, which is just the hands-on, as opposed to what we do in Canada, in BC especially, which is, the RMT program is a little bit different. We can do all of the things, reassure, rule out, refer if needed. Yeah.
That's a good point to make, Stephanie. I think I'm glad you made that, because it is within our scope and we can do that stuff. And it's just because the guidelines, we don't have specific, and we start off with this, right? Talk about massage specific guidelines. We don't have them. Yeah. Back to where we started. I think it doesn't mean that we can't still do the hands-on stuff.
Yeah.
I mean, the hands-on stuff is powerful. We would not exist as a profession if touching people nicely didn't work.
It works wonders.
Yeah, and we wouldn't have 5,400 RMTs in BC alone making a living if people didn't want to be touched. So it's important to understand that the touch is really important, but the other stuff is if you incorporate these other things, it's going to be even more powerful.
Eric, weren't we just talking on social media the other day with someone who was challenging, saying that massage therapy is it really that important in the equation? And my question was, well, I think it depends on what you mean by massage and what you mean by therapy. If we're talking about touching people nicely, which is I think that we don't focus a lot on what feels really, really good.
Yeah.
At least we're not taught that way. We're taught to look for problems to fix instead of trying to understand how it is that you respond to this kind of touch. And if that feels super awesome, then let's stop wasting the time and let's do something that feels super awesome.
Yeah, the seek and destroy method, I like to call it, where you find the sore spot and then you dig into it and press as hard as you can.
That's the weird thing. Sorry.
Does it?
Sorry?
That was it. Just does it get destroyed? Because I don't think it does. I think
no, it doesn't.
It just gets more sensitive. Yeah, I think the way I heard it was we should move from seek and destroy to search and rescue.
Exactly.
Which
I love it.
So good.
Which I don't know who I heard that from. I didn't make that up. Maybe that might have been Sandy Hilton who said that to me one time. Maybe that was last summer at your house, Stefania. You might have said that. I can't remember. But I thought that was great because search and rescue is so much better because you're like, what's the spot that's sore? Let's see if we can make it feel better. Let's rescue it with our touch.
I really like that. That's
Somebody comes in with a great comment. Stop fixing and start helping.
Kevin.
Kevin's great. Thanks for watching, Kevin.
He's my favorite.
I'm thinking that massage therapy still works, though, right? If we just separate them, we could even justify it like that. I started thinking to myself that maybe, because, like we said, people love massage, right?
Yeah,
they love it, and it's clearly doing something for them. And I think part of the problem with the research and why we can't get any robust research on it is because we can't do sham massage. We can't compare against it. Yeah. How are you going to do that? It doesn't make any sense. So touch or no touch, right? So maybe, with all the stuff that we're talking about and putting it in the context of offering massage in the way that we do, which is touching people nicely in a patient-centered kind of way, is I started thinking that maybe people can come to me for the massage that they want and the advice that they need. So I kind of started thinking like massage and therapy. If you don't think massage is that therapeutic, well then, but the rest of the stuff we do definitely is,
Yeah.
Actually, it's funny that you say that because I recently treated someone who said, they come for massage and they feel like it's turning into physio. And this was a nurse, and she said, you guys need to stop trying to be physio and be massage. And I'm like, that's actually really powerful because I feel like a lot of us, we get caught up on this hierarchy of, I guess, healthcare providers, and we perceive ourselves at the lowest, and we actually do have a lot of powerful potential within our profession, and we just need to utilize it more, and we need to stop being something that we're not and start being really, really good at being massage therapists.
I love that. Comment here from Kim. She says our touch can also help our clients connect to their own body. I had a guy recently insist I should be able to see the new surgery scar on the back of his shoulder while he was prone because he had just looked at it. It was on the front. So I clearly wasn't very in touch with his body, but hopefully in treatment we can start to direct that so that they get more in touch. So that's super interesting, Kim. I'd love to hear more about that.
Yeah. That's
go ahead, Justin.
Oh, okay. Actually, Kim, that's funny that you say that because when I was, in my old practice, when I was seeing a lot of pelvic and abdominal persistent pain people, that was one thing, is that they disassociated from that area so much because it was just that mind body or self body was so disconnected because of all the interventions that they've had through that area. And it's something I've been trying to look at and find within research is people feeling that they have to get a medical touch versus like a therapeutic touch, and that a medical touch being something that they have to put up with in order to get results or get confirmation that things aren't wrong or get red flags ruled out, versus like a therapeutic touch is like a nice, non-hurtful, I feel good about getting this area treated type of touch. And I can't find anything on it. So if you have any sources, let me know. But it's just from my bias of treating through those areas, I saw that quite a bit. So.
I think one of my favorite things is my My best friend, who's not a massage therapist, he's a golf pro. One of his favorite sayings is, "If it feels good, do it."
Yeah, perfect.
Yeah,
It just makes sense.
100%.
Yeah.
So one point that I'd love to make, because when we're comparing the two papers that we looked at, when it comes to the treatment end of things, the paper you guys looked at didn't talk about massage or didn't give it as a recommendation. It didn't say not to do it, I don't think, but it just didn't give it as a recommendation. Whereas the one that I looked at makes 2 points. It says patients with acute low back pain who did not respond to initial management or who are screened at being high risk of a poor outcome with a validated prognostic screening tool may benefit from non-pharmacological treatments for pain relief, such as heat, massage, or spinal manipulation. And the second one says that for patients with persistent low back pain with no obvious pathology, non-pharmacological treatments for pain relief, such as exercise, cognitive behavior therapy, mindful-based stress reduction, operant therapy, massage, spinal manipulation, acupuncture, or multidisciplinary rehab programs may be a benefit. So there's 2 things that I love out of that, that they recommended massage twice, but I also love that they talked about mindfulness-based stress reduction. Because we've had several conversations with Keith Meldrum when he's been on, and he talks about how in dealing with severe pain episodes that he has, he just uses breathing and mindfulness as a way to get through it. So if that's something we can encourage with patients, we can have even more of an effect. That's a long silence. What are you guys doing?
No,
That's great.
how can we one up that? No, that's perfect. I think that it just makes so much sense. I mean, we know, I think there is a good body of research which suggests that any manual therapy, and massage included, does provide temporary analgesia.
Yeah.
Right. So why would we not use that for people that are suffering in pain as part of their management plan?
As part of their plan, right? Provided
part of the plan.
Active.
Yeah.
Trouble I see is a lot of patients who come back, and a lot of RMTs I speak with who seem to have patients who are very passive in their care.
Yeah.
You know?
Mm-hmm. And that's one of the yellow flags, is those people looking for just passive care, right? That's one of the yellow flags.
Yeah.
And I think that's an important thing to mention too, is that if someone's coming to see you twice a week forever, and their only management plan is for you to massage them, then you're missing a bigger plan that's more effective, right? So that can be part of it, having them come in, but there has to be the mindfulness, the movement, the stress reduction, the whatever these other things are going on in their life, meaningful activities, acceptance, all those other things need to be part of it as well.
Yeah.
That's an interesting piece. I just want to carry on with that a little bit, because I think sometimes we have a bit of a culture of the therapist becoming frustrated with their patients, thinking like, "Oh, I'm doing everything that I can for you, and you're not even doing anything." So they get frustrated with their patients in that way. And I think that maybe it's not my place to judge on what the value is of their massage therapy. I think that they're the judge of how much value the treatment is giving them in their lives. And if their life is so full and almost literally all they can do is come in for some passive care once or twice a week, I'm okay with that. And what my game plan there is to try and, yes, all those things that you're saying about let's get them active, let's encourage, a bit more care, whichever way that looks. Sing more karaoke, have friends over, play your piano like you used to, or exercise, or whatever it is. But I also just think that if that's all they can do, I want to be there for them. Should they come to a place in their lives where they're searching for a little bit more and say, "Hey, I'm thinking about exercise, and you know what? I know exactly who to ask." So I want to be there for them.
Great.
I just want to know what the hell Jocelyn's laughing at.
Oh, apparently I've been making funny faces the whole time, and I didn't realize. So here we are. But on your point, TJ, actually, I have to say, my experience recently has been really humbling in that regard, because I did see a lot of people who were coming in like bi or tri-weekly for massage. And they weren't there was no treatment plan in place. And so I think too, it's okay, I understand, life is a shit show or it's crazy right now, and this is how you're exercising self-care and me time, and that's great. So let's follow up in 5 or 6 months, or are you comfortable with that? See where we are, and then let's gradually get you back and returning to meaningful activities that are gonna de-stress you or are me time the same way that it is for you coming in and receiving treatment.
I think that's a great idea to have some plan in place and to touch base every now and then. The only point that I was thinking was that where it mattered to people, and thank you for like stretching it out because it helped me find better words, is that I think that it would be valuable for us to remember that it's not about us.
Exactly.
Yep.
And I think it's again, going back to that patient I said who, massage needs to stop trying to be physio, is that that's exactly it.
Mm-hmm.
Put the ego aside.
Yeah, put your ego aside, because and I dealt with that too. A lot of patients in my old practice, they were like, yeah, I don't come here to relax. And I'm like, oh, wait a second. I'm a little offended by that, because I actually give really good relaxation massages. So there was something about my interaction that I had to check, and I was very thankful for that feedback, because if you're coming to, an RMT or a massage therapist and you're like, yeah, no, I don't come here to relax, I don't think that's a good thing either, because that's what we're known for. So
I had a woman cry when she said, we had a back and forth conversation. I was asking her about pressure with the first time appointment. She was like, you can go harder. And I was like, but do you want me to? And she's like, well, no, that would be painful. Anyways, I don't remember quite how it happened, but she ended up saying, she cried on the table and said, I didn't know that massage didn't have to be painful. Oh. I know, right? Like, oh, sweetheart, did nobody tell you that this is helpful even if I don't beat you up?
Yeah.
Okay.
I think
that's a cultural. Sorry, Jocelyn. I would say that's a cultural problem. I think within our profession is that we perpetuate that. Right? People come in, they think that if it hurts, you're doing good, but that goes down to people don't really understand pain.
Yeah.
The general population has a misunderstanding of pain. We, as a profession, and most healthcare professions, don't really understand pain very well. And this is my bias coming out huge here, is that if we understand pain, we understand that doing that shit doesn't help. Right? If someone's in a lot of pain and we inflict more pain on, what are we doing to their system? We're making it more sensitive to pain, right? We're driving it up. And so, that just comes down to, I think it's tough because therapists, they're taught that and people think that. And so therefore they're doing something that they think is in the best interest of the patient. Well, but it comes from a place of misunderstanding or miseducation or whatever. And I think that's really important for us to understand. And that's why I think we do things like this, is to try to, and we all teach, is because we want to get a different message out there, realizing that is not a good, there's no evidence and there's no clinical experience to show that really helps. So it's important we don't need to make people hurt to make them better. I might be able to change that just a little. But
just before you add your point, TJ, I don't want to interrupt you, but we should wrap this up quick. And you can still make your point, but before you do, just want to put it out to anybody, if they have any questions, throw them into the comments so that we can answer them before we go off. Yeah. But TJ, go ahead with the point you were going to make.
Sorry, just getting carried away like we always do together, Yeah, so I can think of a very small handful of people over the last 13 years, but this one particular individual I'm thinking of, they swore that harder was better. Of course, I ended up trying to educate them and letting them know it doesn't have to be that way. It can feel really good, and do you want to try this way first? So we tried, and it took a few appointments to get to the place where I could really give him what he wanted, but it was in between the shoulder blades, drop the elbow, full weight, cross fiber for 10 minutes with all my weight. And now this seems terrible to me and goes against everything that I believe in now. But he swore it made the difference between having a few hours of relief and 5 days. So that was a good reminder for me that the best way is the way that you like the best.
Yeah, and that's a good point, and I'm glad you said it, because it sounds like, what I said was it's if you're doing that, it's wrong. No, because there is those cases where that's what people need, and that's what's going to help them get better.
Yeah.
Even though it makes no sense what we understand from the science, but we know I have a case of a guy I treated who had pain, same thing, between his shoulder blades, like medial scapular, and it had bugged him for like 10 years. And I just dropped my elbows on there and just like hung out forever. And he's had no pain in there since. He's a friend of mine and I see him all the time. And, 15 years ago, he came to see me when I was a student. And then he's like, he still talks about it every time I see him about how I fixed his pain that had bugged him forever. And I don't really know what I did, but I gave him what he needed or what he wanted. And it worked. So that does help sometimes. But I think more often than not, we have to say that, I always like to use the analogy of like, well, if you're going to Vegas, are you going to bet on the odds?
Agreed.
The chances are you might make them worse. There is the occasional time where people might get better.
Kirby.
So anyway, that's
sorry.
the conversation. Oh, Kirby.
Oh, Kirby. Hi.
I want to say, Kirby, since you're listening, that your email you sent the other week made me cry a little bit. It sounds like you guys it sucks down there. So we miss you too. Yeah.
Whereas I'm actually kind of like upset and offended by Eric's last story because I thought I was your only friend. But
no. I have two friends.
Okay.
You're number one, Jake.
Okay. Yeah. So I think we've been at this for an hour and 15 minutes now. So people are probably sick of listening to us by this point. And no questions are coming up. So
okay.
So I think it's probably a good point to wrap it up. I think we covered some of the main stuff. And I think the overall message is work on those soft skills because they're far more important than those hands-on skills. Not that the hands-on skills aren't important, but work on those soft skills, work on communicating with your patients. Anything else you guys want to add?
Sure.
People nicely most of the time.
That's where people can learn about how to, collect and use these soft skills.
And I think I like what TJ said a couple days ago on a post where it's, the golden rule is treat people how you want to be treated, but the platinum rule is treat people how they want to be treated.
Mm-hmm.
Yeah.
Love it.
Yeah.
Perfect.
This was fun, guys.
Yeah. Thank you all you guys for doing this tonight. If anybody who's watching has things that they would like to contribute, we're going to do more of these things. We'd love to have more people on. The more we can spread the message, the more that we can share ideas, the better. The bigger difference we can have in our profession, which I know that's what we're all trying to do at this point. And Eric and I and Jocelyn, we talk about it in our courses. I'm sure, Tej, you talk about it in yours, and Stefani, you probably talk about it at school, is that we're here for support. So if you guys, anybody out there has questions, don't be afraid to fire an email. We're happy to help and we want to continue doing this kind of stuff. So thanks to everybody that came and listened in tonight. Thanks to you guys for participating, and we'll see everybody next time.
All right. Cheers.
Bye.